Hello and welcome to the third Fatherhood Friday. We're very excited to be able to offer these 4 events with you this summer. And we're so glad that you are either returning for the third of our events so far, or if you're joining us for the first time, welcome. I'm Cynthia Osborne, and I'm the director of the Child and Family Research Partnership at the University of Texas at Austin's LBJ School of Public Affairs. And we're really excited to be able to bring together folks who try to serve fathers in a variety of capacities, to be able to learn from each other and share so that we can improve our services and better support fathers and our families. These fatherhood summits are supported by the Prevention and Early Intervention Division of the Department and Family Protective Services. And they fund programs across the state of Texas that serve fathers specifically, as well as families more generally. And we are grateful for their ongoing support of supporting fathers in Texas. And we welcome folks who are outside of Texas. We learn from you and share with you. So thank you for joining us as well. I have a few housekeeping things that I should go over before we begin. One is that if you experience any technical difficulties, we're still in this live virtual environment, there is a technical support button on your screen. And if you click that button, we will be able to try and help you as best as we can. We've also learned that refreshing your screen sometimes helps get rid of the bugs and makes it work for you again. So we hope you don't have any, but if you do have any technical difficulties, please let us know. We also want to hear from you in the chat box. Please tell us that you're here and tell us who you are and where you're from. And if you have any questions, go ahead and put those into the chat box. There are many of you who submitted questions beforehand. My colleague, Dorothy Mandell, and I will be reviewing some of those questions later today. We would also love it if you let everyone else know that you are watching this Fatherhood Friday and share with them that you support dads and families, and let us know what it is that you do and what it is that you learn. If you can tweet, include the hashtag TXDads2020, and if you follow us at CFRPLBJ, we will retweet you. For those of you who know me, that is a lot for me to ask because I don't really know how it all works, but I have people who do, and they will help you, I promise. We also want you to know that today's event will be posted alongside the other 2 Fatherhood Fridays up on the events page at Child and Family Research at UTexas. And you can find us there and all of the other materials that we've put together in our Fatherhood Resource Hub. They're intended to be a resource for you, those folks who are trying to serve fathers and families. And we want to hear from you there and see that they're working and for you. And if there's any additional sorts of resources that we can provide, we want you to let us know. Today's topic is about the perinatal period and fathers during this period. And that word is not something that's commonly used, but it really refers to the prenatal period, as well as right around the time of birth and shortly thereafter. And this is a really important period for the developing child, as well as family bonding. And my colleague, Dorothy Mandell, and I are going to talk to you today about some of the important lessons that we've learned about this period, and how when fathers are not engaged with their families during this period, that often sends a risk, a signal that either the child or the mother or both are at risk, and that the father could use our support as well. Every day in Texas, about 1,000 babies are born, and about half of those babies will be born to parents who are not legally married. And in Texas, as in the rest of the United States, for those children, the biological father is not necessarily the legal father until they establish legal paternity. Most fathers do that in the hospital when the child is born. They add their name to the birth certificate. About 75% of those fathers do. But there are small number of fathers who are not there at the hospital, who do not add their name to the birth certificate, who do not establish paternity. And those are really some of the fathers that we're going to be talking about today and the families that we're going to be referring to. That's about 125 kids every day in Texas who are born to parents in which they will not have a legal father, and the father is not involved in their lives from the beginning. And those are the ones that really send the biggest signal that we need to support those families. The way that today will be structured is that we have recorded our presentations to share with you, and we'll go through both what we know about the prenatal period and father's engagement, and some of the consequences that we know of when fathers are not there. After our presentations, we will come back to join you live and discuss what we might be able to do from a policy or programmatic perspective to better support our fathers, as well as answer your questions. And so we are excited to have this discussion with you and with one another. It's a topic that we both care deeply about. And we, again, are glad that you have joined us and look forward to answering more of your questions throughout. Please enjoy the presentations. Fathers play an important role in the lives of their children. And when fathers are not involved, both the child and the mom are at an increased risk of negative outcomes. And in this presentation, I'm going to demonstrate that this is true even before the child is born. Today, about 2 out of 5 children are born to parents who are not married. And this is a trend that has increased pretty dramatically over the past 50 years or so. And the rates differ quite considerably based on the race and ethnicity of the child's mother, such that about 70% of Black children, about half of Hispanic children, and almost 30% of white children are born to parents who are not married. And non-marital childbearing is actually the norm for children who are born to younger parents, so that about nearly all of children who are born to parents under the age of 25 are born to parents who are not married. And the reason why this matters is not because non-marital childbearing is associated with a host of negative outcomes, including instability in their relationships and negative outcomes for the children. That we care about. But one of the things that's important to understand is that in the United States, when parents are not married to each other at their child's birth, the biological father is not recognized as the legal father to that child until paternity is established. Most of the fathers will establish paternity in the hospital at the child's birth. About 3/4 of fathers will. And there is a federal requirement that all states make it available for fathers to establish paternity in the hospital when the child is born. But this isn't something that all fathers do. And one of the reasons is because not all fathers are at the hospital to take advantage of this. And establishing paternity is really an important thing for fathers to do. It confers the rights that fathers have to their child, along with the responsibilities that they have to provide and care for their child. Some of the rights that go along with establishing paternity are access to your medical records and school records, and to really be able to make decisions about your child's well-being. But one of the first rights that fathers get by establishing paternity is that they get to add their name to the child's birth certificate. Fathers who do not establish legal paternity are not allowed to add their name to the child's birth certificate. And this is one of the primary drivers that we hear from fathers about why they establish paternity so early on. But when fathers don't establish paternity, when they're not at the hospital, these are the fathers that we care a lot about, and especially the mothers and children that are associated with them, because this is a signal that both the dad is suffering from lots of different issues in his life, and that both the mom and the child are at risk of a host of negative outcomes. In research that we did to understand who is it that shows up at the hospital and who is it that established paternity and doesn't, what we found is that out of 100 dads who are not married to their child's mother when the child is born, about 3/4 of them are present at the child's birth. 77% show up at the hospital when the child is born, and nearly all of those fathers will establish paternity then and there. 89% will establish paternity. We know, though, that there are about 23% of dads who do not show up to the hospital when their child is born. There are a lot of reasons that they don't show up. Some are things that are out of their control. They can't get off work. They're incarcerated. They've been deported. Some of these dads wish that they could be there, but for circumstances outside of their control at the moment, they are not able to be there. But there are a number of dads who choose not to be there or who are asked not to be there by the mom. And when dads are absent, most of them do not go on to establish paternity very soon or until they need to establish a child support order. So nearly 90% of those who are absent from their child's birth do not establish paternity. And that's the group that I'm going to be focusing on, the 20% of dads who don't show up at the hospital and don't establish paternity. Those are the dads who are really struggling, and the moms and children associated with them are at increased risk of negative outcomes. And I'm going to show you what the relationships looked like, what their health outcomes look like, the needs of some of these moms. And no matter what outcome we look at, what we find is that when dads are not there from the start, that is really a signal that both the mom and the child need intervention, even during the pregnancy. And that if we can locate and connect with that dad, we might be able to help him to understand how important his actions are even before the child is born. So when we surveyed moms to understand who it was that was establishing paternity and who it was that was not, and who was there and who was absent, what we found is that when fathers are not there at the hospital and they haven't established paternity, this is really a signal that there hasn't been much of a relationship to build on. Now, you may be asking, why did we study moms and ask moms these questions and not dads? Well, the truth is we tried to ask dads, but they are harder to get information out of. And so the moms responded to our surveys, and the dads, unfortunately, just didn't unless they were really actively engaged with their kids. But what we found is if you see in the green bars here, those are the responses from moms who had a dad who was there at the hospital and established paternity. The blue bars show you the responses from moms who were associated with a dad who did not show up at the hospital and did not establish paternity. And I'm going to be showing those differences as we walk through the next couple of slides. And you can really see that among those who were absent, that 2 out of 5 of those folks had been dating for less than 6 months before the mom got pregnant. About half of those dads say, I don't think that is really my kid. And work by Kathy Eden and others has shown that when dads doubt paternity, that's really one of the death nails for the relationship. More than 3/4 of them broke up already during their pregnancy. And although nearly half of all births are unplanned, that 3/4 of those who the father is absent from the child's birth, that their birth was an unplanned pregnancy. We also found that when dads are not there at the hospital and have not established paternity, that's really a signal that he has not been engaged throughout the pregnancy. We found that more than 80% of these dads provided the mom with absolutely no sort of help with getting to doctor's appointments or picking up things at the pharmacy or helping around the house. They provided no financial support, and they never attended any of the prenatal appointments. What we found, what was so interesting, is that about 90% of these dads, 88%, were not at that gender reveal ultrasound. This is the one where you really get to see what the baby looks like. Today's technology is a lot more advanced than it was 20 years ago when I was having children, and you really see that baby smiling at you. But dads go to that. That is something that seems to be really important for a lot of our fathers. But when the father is not at that ultrasound, that's a really strong predictor that he is not going to be at that birth. And if that is a time where we can record whether dads are there or not, and try to reach out and help those moms who don't have a father there, try to connect with those dads who don't show up, and see if we can offer our assistance at that point, that's really a time early on in the pregnancy, before things have gone too far, that we might be able to provide support to both the mom and the dad. They may stay separate. It's not that they need to have a relationship with each other necessarily, but they are going to co-parent. And this is our opportunity, our first time to really see whether he's going to be there or not. We also see that when dads are not there at the hospital and haven't established paternity, that this is a signal that the mom is going to be facing serious pregnancy complications and that the child's health outcomes are also going to be worse. We see that the rate of pregnancy complications is nearly twice that for among those who are absent from the hospital, or their partner is absent from the hospital, as compared to those who have a partner who is present. So 30% among those who are absent, 17% among those who are present experience serious health or complications during their pregnancy. We see that there are big differences in low birth weight, and nearly 3 times the number of children experience serious health complications right around their birth among those who are associated with dads who are not at the hospital as compared to those who are there. We also know that the moms are going to need more of our assistance. So we know that about twice the number of moms who are associated with a dad who are not there at the hospital are going to need TANF. More are going to need Medicaid assistance. But something that's really striking is that 43% of the moms who are associated with a dad who did not show up at the hospital at their birth, 43% say that they have been a victim of family violence, either during the pregnancy or right after the pregnancy. And that signal is a really important one. These moms need lots of support from our family violence programs across the state. Our other programs need to recognize the level of family violence that exists so that we can screen for it and make sure that any of the services that we're providing to moms or to the families themselves are taking family violence into consideration. But these are moms who are going to need our support, and these are dads who need our help, because violence is a signal that something's wrong. We also know that when dads are not there at the hospital, that is a signal that he's not going to be there in the future. That 82% of these dads were not engaged at all with their child since their child's birth. And that they're also going to be the first who are going to need to be part of our child support organization. That the moms, nearly 60% report that 3 months following the child's birth, that they have either opened a child support order or that they expect to in the very near future. And this is an important resource that moms have to turn to try to get support for their child. But these are families that are going to really be engaged in our public systems. And we know that when the dad is not there from the start, that he's not likely to be there moving forward. No matter what we looked at or how we looked at it, we found that father's absence from his child's birth is a real signal of lots of risk during the prenatal period and a predictor of risk of things to come in the child's first year. Both the mom is going to need more help, the child is going to need more help. Now, this does not mean that if we just get all the dads to show up at the hospitals, that all of these risks would be gone. That's not what this is. This isn't a causal story. If it were, we would have a program that was just automatically rounding up dads and bringing them to the hospital when their child was going to be born, and that would solve it all. But that's really not the case. This is indicating that their birth absence is a sign of bigger problems in the relationship. And those bigger problems are the things that are leading to these poor outcomes for both the mom and the child. And so, what is it that we can actually do that might try to support these families? Well, first of all, we saw the high proportion of pregnancies that were unplanned. That if we give couples more control, better enable them and empower them to plan their pregnancies and have children when they are wanting to have them as a couple, that would be one of the first steps that we as a community can do. The next is that we really need to understand that when dads are not there at that gender reveal, that the likelihood of him being involved during that pregnancy or in the child's life are very low. That if we can identify them then, and we can put that in the medical records, we can begin a conversation with mom about, I noticed that dad isn't here. Do you have the sort of support that you are looking for during this pregnancy? Do you have the sort of support that you're going to need when your child is born? Are you interested in our programs such as Nurse Family Partnership or Healthy Families America, Parents as Teachers, other sorts of programs that are really there to support moms as they transition to become parents? Can we find ways where we can safely reach out to the fathers and let them know you matter? You matter for your child's health and well-being. It might not be, like I said, that these are fathers that are going to engage and become back to be a couple with the child's mother. That may not be what we're looking for here at all, but they are going to be co-parents. That father is always going to be the father of that child, and he has responsibilities for that child, and we want him to have relationships with that child. And how can we reach out early enough to get the fathers to understand that they matter, that there are ways that we can help to strengthen their lives so that they can be a positive influence on their children. And this is going to take the hospitals working with us. It's going to take the medical field in terms of OB/GYN and others that are doing all of the screenings. It's going to take that connection to our social service programs. But that's sort of system that we can build so that when we see that fathers are not engaged from the start, that we understand that that is a risk for the child, it's a risk for the mom, and it signals that the father is at risk as well, and that we can find ways to support them.
Hi, so I'm going to talk today about fathers, pregnancy and infant mortality. And this is an offspring of some of the work that we've been doing with the Department of Family and Protective Services, as well as some additional work that we've been doing just generally within our group related to maternal and child health. And what I want to do with this talk is kind of show the central role that paternity establishment plays in understanding and birth outcomes for children. So of those birth outcomes, the one that we are very interested in preventing on the maternal and child health side is infant mortality. And I use that term a lot, and I am going to use it a lot, but I want to explain to you what infant mortality is and why it's so important. Infant mortality is the death to an infant before their first birthday. And it's important to understand that the majority of these deaths are within 24 days of the baby being born. So these are the kids who are dying, the 28 days are the kids who are dying in the hospital. The kids who die after that time are usually the kids who are dying at home. And that's an important distinction to make because some of the prevention programming that we do for these kids who die very early is very different than what we do for the kids who die after this time where they go home. And I also want to emphasize that infant mortality is a rare event. It's still rare, but it's still too common of a birth outcome. And so that's why we spend a lot of time and a lot of effort looking at ways to prevent infant mortality. And currently in Texas, we're doing not too bad on infant mortality. We have a rate about 5.8 deaths per 1,000 live births in Texas. So for every 1,000 children born, about 5 of them die before their first birthday. It's still a high rate when you look at other developed countries, but it's not that high of a rate looking at it. We're starting, our infant mortality rate in Texas is about comparable to what the entire European Union looks like. And when we talk about infant mortality and talk about preventing it, it's important to understand that this is really complex. There is a multifaceted chain of causal events that lead to the death of the child, of the infant. So what's important is there's almost never one thing that leads to death. There are certain genetic conditions that is that one thing, but even with those, there are a host of predisposing factors that lead up to that point. And majority of the deaths that we're looking at a causal chain of multiple things that build upon each other that lead to that infant's death. And the other reason why we spend a lot of time talking about, as a friend of mine put, dead babies, is because it is the best reflection we have about the health of a community. There's nothing more that could be said about the community than sitting there and looking at it and saying, how many babies in your community are dying? Not only does it hit us in an important place and it motivates us to do something about it, but it makes us look outside of our community a little bit and look outside of ourselves to say, well, as a community, what are we doing? And so I want to kind of show the importance of this, because infant mortality also has a whole host of disparities that we see around it. And this comes from some of the work that we've been doing on zip code level matching and population health, zip code level infant mortality work that we've been doing within population health. And that there are substantial racial ethnic disparities when it comes to infant mortality. While our white families have a very low rate of infant mortality and our Hispanic families have a very low rate of infant mortality, our African American and Black families tend to have an infant mortality rate that's almost twice as high as these other race ethnic groups, which is a very big disparity. It's not the biggest disparity that we see in maternal and child health, but it's an importantly big disparity. And part of that is that it reflects, like I said, substantial geographic disparity as well. That our communities are not all equal when it comes to infant mortality. We have a lot of communities whose infant mortality rates are too high, way too high. We have quite a few communities who are doing incredibly well and their babies are surviving past their first year of life. And a lot of other communities that we're looking at where this is not true. And so that's why it reflects the health of the community. It is a disparity that we see across race ethnic groups, but it's also a huge disparity that we see across Texas geographically as well. So that leads to another point, that is that when we usually think about causal relationships and what is leading to death, we are thinking about, all things being equal, what causes infant mortality? Is it a genetic condition? Is it hypertension? Is it diabetes of the mother? Is it lack of prenatal care? Is it important care that was given within the NICU or within the hospital? Are these events the causal events that led to the infant's death? That's usually what we talk about. I don't want to talk about that. What I want to talk about is this: what isn't equal? Not all things being equal, what caused infant mortality, but what isn't equal across our communities, because by starting to look at what's not equal across our communities, we can start addressing some of these issues. And because we're talking about fathers, I want to focus particularly on paternity establishment and its role in what we see as something that is a disparity and isn't equal across our communities. The other ones I want to talk about are smoking and no prenatal care. Both of these are super high risks for infant mortality. We see across the entire spectrum that smoking, when women smoke during pregnancy, the rates of infant death go up, the rates of low birth weight go up, the rates of all sorts of bad birth outcomes go up. And we also see this as an important indicator for disparity in a community as well. No prenatal care is also another one of those things that we see across the board. No prenatal care. And I'm not talking about women going in for one visit and then not going ever again. I'm talking about women who just don't seek prenatal care during their visit. That is a risk factor, not just for infant mortality, but for low birth weight, preterm birth, a host of complications that baby might have immediately after birth and within that first year. And what I want to talk about is how paternity establishment kind of overlaps with both of these important risk behaviors that we see. And this is a Venn diagram because, in fact, we see a lot of overlap between these, that women who don't seek prenatal care are more likely to not have paternity establishment, and that women who smoke also are more likely to have paternity establishment. But I want to talk about how these three things interact with each other. So first of all, I want to get a baseline understanding of paternity establishment, because I feel like when I have these conversations, I often have to talk about this, is that paternity establishment is actually the norm. It is not the exception. 86% of babies who are born in this state have paternity established. When you look at racial ethnic disparities, you just do start seeing big racial ethnic disparities. But at the same time, even for our ethnic group or racial ethnic group that has the worst paternity establishment, it is still the norm. 67% of babies born to a Black mother have paternity established. And I also want to make the point too that just because paternity wasn't established doesn't mean the guy's not around. And we can talk about that later. The other thing that usually comes up is people will tell me that paternity establishment is an issue for teen mothers. And it is true, it is an issue for teen mothers. 62% of teen mothers do have paternity establishment, do have paternity established. But when you look at the overall distribution across all of our age range, who's at risk? Who is contributing the most to babies being born without a father named on the birth certificate? It is 18 to 25-year-olds. Teen births, even though we have a very high teen birth rate, still makes up a small proportion of our births in the state. 18 to 25-year-olds make up a large proportion of births in our state. And paternity establishment in that group is only 80%. But what is 80%? But what's important is we look at all of the babies who don't have paternity established, we see that 54% of those babies are born to a mother in the 18 to 25-year-old range. So that's important to understand for a bunch of reasons. First reason is that when you talk about lack of paternity establishment, it's not the norm, it's the exception. And the other thing is it's really with these young but not teen moms where we see the highest risk for not having paternity establishment. So what about infant mortality and how that relates to paternity establishment? Well, what we see is that when paternity is established, the infant mortality rate that we see that is only 5 per 1,000 infants. To put this in perspective, that puts us on par in the middle of the pack with most European Union countries. So when dad signs the AOP or the parents are married and he automatically establishes paternity, you're talking about a very safe outcome for the baby. It's a very safe situation for the baby. It's not that his establishment suddenly makes that baby not die, but it is an important, whatever is underlying that is important for helping her and helping that baby have a very healthy pregnancy. And when you put this in perspective, when paternity is not established, what we see is a significant increase in the infant mortality rate, where it raises to about 8.5 per thousand births, which is the state as a whole had an infant mortality rate of 8.5. This would become a public health emergency, frankly. So we see a significant rise in infant mortality just when paternity is not established. So to put this also in perspective, because like I said, paternity establishment is the norm, not the exception. If we put this in perspective of how many babies' lives could be saved if this group, the paternity not established group, had the same infant mortality rate as this group, we'd be looking at about 1,000 babies over the course of 6 years that would have made it to their first birthday. In public health, we often talk about this in terms of these are excess deaths. And so we're looking at about 1,000 excess deaths associated with this infant mortality rate of 8.5 versus this infant mortality rate of 5. So this is a big impact. So let's dive into this impact a little bit and see how it interacts with other behaviors that we see that are also risky. So that's important to understand. It's just not one thing. So you don't have paternity not being established in isolation of other risk factors. They actually exist within other risk factors. And one of the biggest risk factors they see it intersects with is smoking during pregnancy. Smoking during pregnancy is very risky for mom and it's very risky for the baby. The outcomes associated if mom smokes during pregnancy are very well established and they're not very good. Low birth weight, higher rates of early preterm birth, as well as higher rates, as you see, of infant mortality. So if we just take those women who smoked during pregnancy, but the father was there and paternity was established, we're looking at a very high infant mortality rate. And this is a protected situation, right? We're still looking at 9 per 1,000 babies dying in this situation. However, if we now move it into a situation where paternity isn't established, this infant mortality rate increases. Now, this is not quite a statistically significant increase, but I think that what you see here and what we see consistently is this infant mortality rate is elevated in comparison to smoking, but paternity being established. So that's an important thing to recognize. But what's also important to recognize is that the protective factor of paternity establishment. And that when you break this down and flip the question and saying, well, if paternity is established, how many women actually smoke? What you see is that once paternity is established, only 3.7% of women smoke. Those whose pregnancy has no paternity established, 9% of those women smoke. So there's some stress factors going on here, as well as some other things interacting here that are important to understand. We see this also with prenatal care access and just even going to, like I said, just going to one prenatal care. We're not even talking about high quality prenatal care or accessing a lot of prenatal care. We're talking about, did you go just once? And the infant mortality rate for women who receive no prenatal care at all, but yet paternity is established, is 16 per 1,000 babies. That is really high. That is a lot of infants dying. And if you let me translate this into a much more understandable metric, that's 1.5% of the babies in this situation die. Now, if we add onto that paternity not being established, what we see is this rate significantly increases. And it significantly increases so that it's almost 2% of the babies in this situation are dying. So no prenatal care and no paternity establishment, that baby is at very, very high risk for death. Now, once again, this is also flipped on the other side, as if we ask about, well, what does prenatal care utilization look like with paternity establishment versus without paternity establishment? We also see this significant difference, that women whose baby has paternity established are very likely to access prenatal care. Only 2.8% of them don't access prenatal care. If paternity is not established, about 8% of them don't access prenatal care. So once again, paternity is also playing a protective role in this situation by increasing the good behavior that we want to see. So I'm always hesitant to talk a lot about a lot of data, but I did anyway. But so this is what I want you to remember from the situation. Paternity establishment overlaps with high-risk behavior. Lack of paternity establishment and high-risk behavior go hand in hand. The other thing to understand is the paternity establishment and the high-risk behavior, they actually make each other worse. So any bad outcomes that we would see with no paternity being established are amplified with these high-risk behaviors, which we know exist together in unison. So lack of paternity establishment and high-risk behavior makes these high-risk behaviors more high-risk. And we especially see that with prenatal care. But the flip side of it too is, which is important because this is our norm, is that when we establish paternity, when paternity is established, so he is there and he is going to take responsibility and he's going to be a part of this baby's life, or he at least he signs the APO so that he gets named as the father. That situation makes it so that low risk behaviors are even lower risk. So it makes the high risk, not establishing paternity makes the high risk behaviors more high risk, but establishing paternity makes these low risk behaviors lower risk. So to put this more succinctly, when paternity is established, the good things are better. So from a prevention standpoint, now gets us into the question is, how do we make these good things better? Because that's what we want to do. We don't want to punish the bad things. We want to make the good things better. And I think that it's important for us to step back and think about, well, what leads to paternity establishment? Because this is an event that happens when the baby is born. Most of the time, they're establishing paternity at the hospital when the baby is born. So unless the parents are married, and then they don't have to establish paternity, it's assumed. So it doesn't start at birth, just like fatherhood doesn't start at birth. It starts much earlier than that. It's a journey, and paternal involvement does not start at birth either. It's a journey from conception all the way through birth. So when we look at this and we think, like, how do we bring guys in to make these good things better? The big question is, how do we create an environment that makes the journey positive, from these positive to get to the point where paternity is established? So we have to step back then and ask ourselves, what does male involvement in the pregnancy care system look like? What data do we have that actually shows us that male involvement, how men are involved in the pregnancy care system? And this is a list of what we know. What you see is not much. And this is a list of what we don't know, which is a lot of things we do not know in this situation. So what we don't know, we do know that pregnancy affects men biologically. That should be the norm that we communicate all the time, that men change too. They're also going through biological changes during this time. And men feel underprepared when the baby is born. Also, I want to emphasize that men want to be involved. The data show that over and over and over again. And so we as a system need to figure out how we bring guys in to let them be involved so that they may feel more prepared and they can be aware of these events that are happening to them. So what we don't know. What we don't know, and one of the things that I find really shocking that we don't know, is we don't know the percent of men who attend at least one prenatal care visit. We don't. We have some small studies that suggest that it's a large proportion, but we actually have no national surveillance whatsoever surrounding how many men go to at least one prenatal care visit, or how many men or percentage of men are actually involved during the pregnancy at all. We actually have no surveillance on that whatsoever. We do know how many women experience domestic violence during their pregnancy. We do know some other things about negative male involvement, but we actually have no data on positive male involvement. And with that, then, we also have all sorts of information that we don't know about men during prenatal care either. So one of the things our group has been trying to do is, one, we're trying to fill some of these gaps research-wise, but the other thing that we're trying to do is not wait for those research gaps to be filled and actually start bringing men in and start figuring out from what we do know is how can we make this journey more positive for them. And that is through the Father's Playbook app that we have helped develop along with the Center for Health Communications, who's done a lot of the amazing formative research to develop the app. And what we're trying to do on the Father's Playbook app is actually help dads be engaged and stay engaged during the pregnancy. And we're doing that through some very important ways. Is one, we're addressing a need that guys say that they have related to what they want to be prepared for when their partner is pregnant. And that is being financially stable and understanding what they need to pay for and how much this is going to cost. And babies are expensive, and they're expensive to prepare for. So we provide tools to guys to help them budget and to help them understand how much things cost so that they can make decisions about that I'm going to buy, and if I buy that, then I don't want to buy that. The other thing that we're helping them do, and we're really pushing, is the importance of going to prenatal exams. We are very fortunate to have research that Cynthia's group has done about the importance of that prenatal exam, and just going to one prenatal exam and how much that helps with that establishment of paternity when he's on the fence about whether he's going to be involved. And so we want to do a lot to help foster that and bring that forward within dads and help them identify and help them figure out how to go to these prenatal care visits. The other thing that we're going to be adding is some action plans and some postnatal content to the app as well, and I'm happy to talk about that later. But I do want to also bring around one other point that we're trying to do, because I know that later on we're going to be talking about policy implications, and that is COVID-19 and what that has done to dad's involvement. And what has happened during COVID-19 is prenatal care visits have been shut down to visitors. Only women go to prenatal care visits now. A lot of those visits have been moved to telehealth. Some of those visits have been moved to telehealth, but the one-on-one visits, only the woman can go to them. So now it becomes this strategy that we've been utilizing has been, we think, shut off to this, is can men actually go to prenatal care visits now since the new regulations associated with COVID-19? And how have OBs responded to this, and are there innovative and best practices that we can use and support? So one of the things that we're doing with the Center of Health Communications is we're rolling out some surveys surrounding this to try to get a better understanding of how these changes have really affected father involvement. Because the last thing that we want to do is make and encourage a strategy that isn't a strategy that they can actually engage in. We don't want them to send them on a frustrating journey. We want to make the journey actually something that's going to lead to paternity establishment, not something that's going to frustrate them more and make them back away. So we're trying to understand what this looks like for men right now. So with that, I just want to leave you with this, is that we measure what we value. This is a mantra that we have in public health a lot, is that we can't improve something if we don't measure it. And it's something that I would like to challenge all my public health colleagues with, is we're not measuring father involvement. Paternity establishment is not involvement. And we don't measure his journey at all during the pregnancy. So with that, I'm going to end it there.
Well, I hope that you enjoyed both of those presentations, or at least were able to learn a lot. The content is not necessarily that enjoyable. But Dorothy, this is a topic that we've been studying a lot. We both somewhat found this correlation a little bit by happenstance, in that no one had really been looking at what it meant for fathers to be present, or how big of a risk factor their absence was. We know that father's absence throughout a child's life has been studied as a risk factor for a long time, but your look and how it's such a risk factor in infant mortality, and our understanding of really what it signals during the pregnancy and after birth, is somewhat new information, and information that the state has taken into consideration. It's retrained its birth registrars, who are folks who are at the hospital offering the opportunity for unmarried parents to establish paternity. These are things that folks are aware of, but I think that we need to do more. One of the things I just wanted to clarify before we go any further, because this is something that really comes up again and again. You emphasized it, I emphasized it, but this is not a causal story. I'll give you an example of how this was misinterpreted. One of my students, graduation day for him fell on the same day as his child's due date. And he came to my office and he said, "I saw your presentation and I am going to miss my graduation because I am not going to miss my baby's birth." I told you, you said that if I miss my baby's birth, that everything is going to go wrong. And I said, well, first of all, you failed the class because you don't understand the difference between causation and correlation. But second of all, that's not really the case at all. There are circumstances in which sometimes fathers cannot be there. It's the fact that we have couples who have relationships that are have other sorts of risk factors or other things that are going on, and you were able to point out quite a few of those, that it is a signal that there are problems in that relationship. There are supports that those parents and the child is going to need. So I just want to reemphasize that, because I know that this is something that folks care a lot about. But where do we start, Dorothy? What would be the first thing that you wish that we could do, besides having more information and measuring, which are two important things, because we may not know all the answers until we know more of the issue or the problem. But where would you start? What would you do first?
Well, shoot, you took away my start. I want to start with measuring. I still remember the first time you and I talked about this, and I realized, Cynthia, that was almost 8 years ago.
Oh, wow.
When you and I first talked about this, and we had a discussion about how do we get that question added to prams. And it breaks my heart. It's still not on prams. How many did your partner or the father of the baby go to at least one prenatal care visit with you? It's still not on the prams nationally, and it's not on our state level prams. And so while you took away measurements.
Sorry, I didn't mean to interrupt you, but can you just explain what PRAMS is? I'm not sure everyone's aware of that.
Yeah, so PRAMS is the Pregnancy Risk Assessment Monitoring System. And this is a system that's put together by CDC, and the majority of states in the country utilize the PRAMS question to do a lot of surveillance surrounding early maternal health and its relationship to birth outcomes. So everything that we know, for example, about pregnancy intention actually comes from PRAMS. Everything we know about, not everything we know about, but a lot of our estimates for domestic violence comes from PRAMS, and for many situations, we're utilizing prams to understand what the rates of postnatal depression are as well. So it's an important surveillance system. And that one question, just did he go? We still, 8 years later, we still don't have it on prem. So while you took away measurement as the first thing I would do, I'm going to put it back on the table because that would be the first thing I do. So because it's so important, and we're hitting this across so many different places of trying to advocate for making the clear distinction that he should be there, and let's do policies about trying to figure out how to open that door to get him into that prenatal care visit, and not put up policies that make it harder for him to get into that prenatal care visit.
Right.
I kind of wanted to push it back to you about that, Cynthia, because this is something that we've talked about quite a bit too, is what policies can we put into place? What are you seeing as successful for being able to open that door for him to that prenatal care visit?
Yeah, so I think I just want to clarify, because I think it's an important distinction or point to make, is that there are some couples for whom they should not go together to a prenatal visit. They probably, it is healthier for them not to be together. As you pointed out, that is more the exception than the rule, but we did find a really high level of domestic violence among moms who do not have a father present with her. So we definitely need to make sure that we're screening for family violence in all the things that we do. But I don't want us to think that all dads are dangerous. We need more dads to be able to come and feel welcome at these prenatal visits. I remember my husband's experience, and he felt a little bit like the wallpaper that it really was for, me and about the child. And having that, you can imagine he was a highly educated 30-year-old, and where you were demonstrating that it's so many of our younger parents, sometimes at risk for other sorts of things, that they're having a hard time advocating for themselves or feeling as if this is a place that they're wanted or needed. So I think there is some work that needs to be done in training our OB/GYN about how important father support really is, and ways that we can make them feel more welcome and accepted at that visit. I think that I would love to see more efforts toward things like paid time off. A lot of moms have a very difficult time taking off of work in order to get to her prenatal visits. But for fathers, that can be even more difficult, that they can't just say that I'm going to go to this visit without threatening losing their wages or their job. And so paid time off for medical care, it would be important. What's difficult is that he isn't the legal father of that child if they're unmarried. And so we had talked about things like having him be able to have a visit himself to make sure that he is healthy and that there are no needs that he would need. But he's not covered by Medicaid. Childless adults are not covered by Medicaid. And he isn't the parent of that child until paternity is established. So there's some real barriers to being able to do some of these things. But I do think setting the norm and the expectations that dads can go. I think finding ways to deal with the privacy constraints that are real, but including it in the electronic health records of who's at the visit, if the mom agrees to that, and being able to build partnerships between our parenting programs or home visiting programs and our OB or clinics, that when moms show up and a dad isn't there, that there is a conversation about whether she has the support that she needs and wants, and that would be an opportunity to really bridge those two sorts of systems so that we could refer those moms into our programs as early as possible. But there's so much more to do, but I do think that some of these things are really just identifying and training and setting the norms for what we want out of our prenatal system. But your fatherhood playbook, how is that? Tell us a little bit more about that and the messages that it sends to dads about their important role that they play during the perinatal period.
Yeah, and really have to credit Mike Necker who's at the director for Center for Health Communications, not health statistics, health communications here at UT Austin. He really did a lot of the formative work surrounding the Father's Playbook, and it's a really interesting story that Mike tells about why he did it, and that's because his wife was pregnant, and he wanted to learn more. And everything out there was for women. And it really, he's like, this is not for me. So he set out to like, well, what would this look like for me? And what do I want to know? And did a lot of the work that established, well, this is important for guys. Financial planning is important for guys. Understanding and normalizing that they change during pregnancy is incredibly important for guys, without putting in all the, his group likes to talk about the scary uterus videos that is often in women's pregnancy apps. And one of the things that we see that's powerful with the app is that we can actually reach a lot of guys with it. You know this very well, that actually reaching the guy is very hard, especially during pregnancy. And especially in those situations where they are not married. You have to have the mom as a gatekeeper to find and to talk to dad. And that creates a difficult situation, because everything then becomes, every conversation you have becomes a little bit through the lens of what she's willing to gatekeep to get you to him. So one of the things that we wanted to do was establish a line to him that didn't require that level of gatekeeping. He can seek this out and he can get information for himself without all that information being going through her. And I like that for a couple of reasons. One, because he needs to change, and he needs to recognize what it is that is happening and his role in that, and that's what we're hoping to do with the app. But the other reason why I like it is, from my perspective, why is mom gatekeeping everything? Why is she gatekeeping all of the messaging? And honestly, I initially came at the Father's Playbook from that perspective of, we need to stop putting all the information burden on mom. And since then, I've become where's dad in this whole situation, in recognizing how much we've left dad out of prenatal care visits, as well as pregnancy information generally. So for the Father's Playbook, we kind of have this idea of a much more generalized audience for the playbook. But at the same time, most of our information is really sculpted towards that, helping that guy who's on the fence be on that right side of the fence. So we also have information in there about paternity establishment and what that looks like, and why it's important, if he's not married to her, to be at the hospital, because it makes it a lot easier to establish paternity than it is to do it later. So we have articles that emphasize that. We also have some articles about his central role in breastfeeding decisions and what he can do to help her during breastfeeding. So we want to, that's part of the making him being there makes the good things better. And that's part of also emphasizing that, and not emphasizing just the negative of his absence. And we also have a heavy emphasis on mental health. And that's become a huge passion of mine, is emphasizing and getting other people to recognize that men experience perinatal depression and perinatal anxiety too. And I've been amazed in the past 5 years about how much this has started coming up more and more in conversation, and I'm very excited by that, because we need to pay attention to that situation, because when you're depressed, you withdraw. And these situations where she may be open to him being involved, he may be experiencing depression and then back away. And so this mental health and having awareness of mental health and what his own, how this is affecting his own mental health, has been something that we've been trying to raise awareness in through the app as well.
Yeah. Yeah, I mean, this is an area that really, it's amazing that it's 2020 and that we are really just recognizing that men really are the other half of this whole equation of having kids, and designing something that is really intended for them, not to go through mom, not to be interpreted by someone else or their mom, but that it really is for dads. I think that's what I love about that playbook. There were a couple things I just wanted to emphasize, because I know that in some of the questions that this is coming through, and I want to clarify this as well. There are good reasons that men should not establish paternity. I don't think either one of us are suggesting that all men should sign an acknowledgement of paternity form in the hospital. If there is any reason that you doubt the paternity, that whether you are the legal father of the child, that you should not establish paternity. There are other processes that you can go through. You can take a DNA test. You can do this in a courtroom, child support office. There are other means of doing it. So there's sometimes really good reasons that folks have for waiting and making sure. But what we're really talking about is in those situations in which you really aren't sure about the paternity, that is sometimes a high risk pregnancy or high risk relationship. When there are fathers, we've met some dads who they didn't establish paternity because this was one of the things that kind of broke my heart. He didn't have his high school, or I'm sorry, all he had was his high school ID card with him. And it didn't have his middle name on it. And so he really wanted to make sure to get some legal document that demonstrated his middle name, because he wanted his child's first name to be his middle name. And so on the birth certificate, he wanted his full name, and he didn't have it. Well, it's hard sometimes to go back through and to take the time away to go and sign these legal documents later on. And a couple of years later, they just still hadn't established paternity and hadn't added the dad's name to the birth certificate. So there are situations that arise in which they really would like to be involved with the kid, and for various circumstances, they're not establishing paternity. But for what we're really trying to point out is those situations in which the couples are not together, and the father is not engaged in the relationship or with the child. Dorothy, I wanted to, one of the things that you find and one of the things that we find is the high level of unplanned pregnancies, as well as the high level of young parents that this is affecting. And I'm wondering if you wanted to speak to either of those issues. We've been doing a lot of work on young parents and especially young fathers. And, they simultaneously are making all these decisions that as we transition to adulthood, we usually space out. We graduate from high school, we go to college, we get a job, we get in a relationship, we have a child. And those steps are something that usually take people 10 years, not usually, but it takes a lot of time for a lot of people. And for our young parents, they're doing it all in a couple of years, or even sometimes all at once. And can you talk about any of the, whether the app speaks to this or any of the work that you've done really speaks to how do we deal with our young parents who are really trying to take this all in at one time and make these decisions about how to be engaged in their kids' lives and get them to understand how important their role is?
Yeah, and this is one of the things we're trying to do in the app with the action plans, is for the action plans in the app, they're mainly about, this is built on some of the work that we've been doing with moms and engaging moms in early child development and relational health, is putting those action plans in there for him too, to recognize that he is a big deal when it comes to the development of that child in a different way than she is. And recognizing that his role is important as well, and he needs to make a plan for being involved. And you can't just assume it's going to happen. He's going to make a plan for being involved. I think that even high resource parents, to be honest, you need to make a plan to remember to, have fun with your kid every now and then. And that's what we're trying to do through the action plans. That all conversations around unplanned pregnancy always center back around about birth planning and contraception access. One of the big mantras that I've always had and have had through some of the maltreatment work that we've been doing is, when you talk about those risk factors of what should raise an alarm bell for you as a provider, the other one that I see is, one is unplanned pregnancies, and the other one I see is rapid repeat pregnancies. That I don't care who you are, if you have a little baby at home and you're pregnant with another baby, that's a really difficult situation. And caring for two young children in diapers is a very difficult situation. And you talk about this a lot of, as well as like, what is the alarm bell for a provider to connect somebody to additional social services? I see the unplanned pregnancy and the paternity establishment being those two alarm bells that you should connect somebody to the services. I don't care how researched you are, these are difficult situations, and rapid repeat pregnancies is another one of those situations. This is a difficult situation, and we could all use additional support when it comes to that. With that said, our young families in particular, that I don't want to say that they're automatically at risk, because that 18 to 25-year-old range that we see for a lot of outcomes, that's actually a really safe time to have a baby. You start getting into the 30 and upper 30s, that becomes more difficult time to have a baby, but that's a safe time to have a baby biologically. It's a difficult time socially to have a baby. And why can't we just say, let's give each other more support and give these families more support? It's the difficult situation, I think, that we have of justifying who should be receiving additional support and who doesn't need additional support. All right, I just turned this into a universal, let's do a universal home visiting program, Cynthia.
That everyone gets screened and gets the services that they need. That's a model. It is a model that we're starting in several different communities in Texas, the Family Connects model, where we will understand what the needs are of all new moms. And we know that all new moms, regardless of their socioeconomic status, have questions and challenges and needs when they become parents. So that program is universal for anyone who wants. It's voluntary, but it is, we're seeing that it's an important program, and we're asking them to ask about the dad as well, to make sure that if they are that they're able to co-parent even if they're not in a relationship. I want to make sure our time is somewhat limited, and we've talked a lot about the risk factors. We've mentioned that if dads are not around, that is a signal that the dad is probably in need of help, and that the mom and child certainly are. But let's spend some time talking about, when he is there, what is his unique contribution? You mentioned that you share this sort of information in the app, and I know that you've looked at this and we've looked at it as well. But your fathers actually play a really important role in the pregnancy and the health of the developing child, and postnatally. and it can come from just being there to be supportive. It can be going in the middle of the night, like my husband did, to find me a hot pastrami with Russian dressing, which is just awesome. But it can be as simple as saying, you have this. I support you in trying to breastfeed this child. I support you in the way that you are, thinking about feeding this child and all of these different things. But do you have any sort of things that you want to add or emphasize about when dads are there, what are they doing that is actually making a difference?
Actually, we're trying to launch a study, and COVID kind of got in the way. We were about to launch a study that actually, well, what is he doing? What are these informal and formal support systems? And on the formal side, one of the things that we see in the literature is dads being a stress they help mitigate the stress of being pregnant. And you can't de-emphasize that enough, is having there somebody to help you not be stressed out all the time. When you talk about where the biological mechanism is for a lot of these bad birth outcomes, stress is a big deal. It's going to exacerbate a lot of other things that we see happening during pregnancy, like hypertension and diabetes and other things that arise during that pregnancy that may impact the baby, or it may impact mom. So that's really super important. The other thing that we would like to do more work on, and are hoping to do more work on, is his impact on nutrition during pregnancy, and how much his role changes during the pregnancy to help take over some of just existing in the world for her, to make it easy for her. Things like cooking or doing additional chores, or taking on whether or not the balance of duties within the relationship shift, so that he takes more of those duties during pregnancy. So we're currently trying to do some research about this right now to help, because we want, especially on the nutrition side, we want him to be an agent for good on the nutrition side, and definitely not an agent for bad. So yes, on the hot pastrami sandwich with dressing, but probably no on the cake every night,
Not every night.
Yeah. So it's a big emphasis that direction we're trying to go currently, is understanding what he's doing, because frankly, on the prenatal side, there's not a lot of work when it comes to this. We know that there's something protective going on, but really there's not a lot of work to quantify what that protective behavior is. And so that kind of has made it hard in the app to then say, we really want to encourage this behavior, and this is behavior he's willing to take on, so we want him to encourage him to do that. So I think we know a lot more postnatally about father involvement and its impact on children, but prenatally, we don't necessarily know a lot about his positive impact on the pregnancy.
Right. We know the absence of it makes a big deal, a big difference, but what he's actually doing, we're not exactly sure. But I do agree that the mechanism really is through stress. It's through social support. It's through helping this transition as a family, and knowing that you're not doing it alone. Neither the mom's doing it alone or the dad. So I know that we have to kind of come to a close. I'm wondering if you have any final thoughts that you wanted to share before we start talking about what we're going to be doing in our next Fatherhood Friday.
I think that one of the final thoughts that I have is for all those providers out there, is that every time I talk about this, I always get a provider inevitably who tells me it's not my business to ask about their relationship. And I hope that you see it as your business. Your business is to make that pregnancy healthy. And this is an important risk factor for understanding the health of that pregnancy. So this has been one of the things I've been doing the past 5 years, is trying to get providers to understand that this is their business, is to ask if he's around. So, yeah. Cynthia?
No, that I couldn't agree more. And that goes to just the way that our health providers think about the couple having a child, not just the mom. The way that we treat dads when they're with us at the clinics or in the doctor's office. It goes to certainly with both screening and privacy constraints in place. We need to deal with those things, but it goes to including him in the medical records. Understanding whether he's present and if he has any risk factors. We've always said that a healthy mom equals a healthy baby, but a healthy dad often equals a healthy mom equals a healthy baby. And so having the bigger picture of the whole family and what's contributing to these healthy birth outcomes and ultimately healthy child outcomes is really important. And it's a big glaring signal in public policy. We look for these things that are easy to detect without big screeners. And if dad's not at that gender reveal, if he's not showing up to any of the prenatal visits, that is something that's pretty obvious. And our providers, our health providers, need to know that there's a service organization in their community that they can call and they can try and get those families connected. The mom knows who the dad is. And if we reach out to her and say, is there someone who can reach out to the dad and support him through this, we really might make a difference before the child is born. But certainly at the birth, if we see that the dad is not there, if he's not establishing paternity, we need the nurses, the birth registrars, they need to be noting that and getting support for that mom, that baby, and hopefully for the father too. So I've really enjoyed actually being able to have time to talk with you, Dorothy, about this. It's something that, it's a conversation that's been ongoing for 8 years, but we just never get enough time to really think it through. And I'm hoping that we see that things are very different when we're talking about this 8 years from now. But thank you again for your time today. I really appreciate it, and for the work that you're doing. That Fatherhood Playbook app is on our Fatherhood Resource Hub. We link to it and make sure that folks have information about it. But it is Texas-centric now, but applicable to all fathers across the country. And I know that that's something you guys have been thinking about even more broadly. So thank you again for all that you're doing and for the conversation today.
Thank you.
So we thank all of you for joining us again. We have completed our third of 4 Fatherhood Fridays. And on July 24th, we're going to talk about fathers and public policy. And one of the big public policies, I guess, that really impact fathers is the access and visitation rights that they have with their children. I don't like the term access and visitation. That's a federal term that's used. I prefer parenting time orders or some other way of signaling that these are co-parents who are working together to raise a child. And our courts have established guidelines as to, at least at a minimum, of when each parent should be with the child and seeing the child. There are a lot of folks who have concerns about times in which the fathers don't have access to their children despite an order. There are a lot of moms who are concerned that even though they have an order, the father hasn't shown up to see their child. These are issues that we will discuss, and we will have folks who can tell us about the enforcement of some of these orders. I know that that's a big concern, that child support is through one court system and parenting time orders are done through another court system, by and large, within the state. And that kind of dual arrangement can be very costly and time consuming and difficult for families to navigate. So this is an issue that we know is very important to so many families, and we're going to discuss it on July 24th. I'll also share more about policies kind of writ large and whether in what ways they do address fathers or leave them out, especially when fathers are unmarried. And a lot of our policies are geared for whoever the resident parent is with the child. And more often than not, the resident parent, the one who lives with the child for more than 6 months out of the year, is the mom. And so a lot of our policies really just focus on a mom-child dyad and leave dads out of the picture. So we're going to talk about some of that on July 24th as well. I encourage you to submit questions beforehand. We really want to make sure that we can address your questions during the conversation. But if you can submit them beforehand, that makes it easier, especially when we have lots of different panelists, so that they can be sure to address them moving forward. Again, I hope that you share with everyone on Twitter that you are here at hashtag TXDads2020, and let folks know that you do support fathers. And also, please continue to share with us. We want to learn more about how you're putting to use any of the things that you learn in these Fatherhood Fridays, or the things that you find useful on our resource hub, or the things that you would like to see more of. So please continue to communicate with us so that we can better serve you. So our time is coming to a close today, but please join us again on July 24th to talk about parenting time and fathers and public policies and fathers' involvement in both of those. And thank you again to Dorothy for her contributions to today. And this video will be posted on our Fatherhood Resource Hub, Child and Family Research .utexas.austin.edu. Anyway, thank you again, and please stay safe, and we will see you in 2 weeks.